Here to the third day of the late summer school 21. I hope you are all well rested after the late evening yesterday and can start with full energy into the third day. Jonny Wilkinson, graduated at the University of Liverpool, is now a consultant in intensive care and anaesthesia. He will talk us through sonography of the lung and the deep vein thrombosis. Please welcome Jonny Wilkinson.
Okay, morning everybody. I hope you've enjoyed the last few days. I'm very sorry I'm not actually with you in person, but so I'm hiding behind the camera here, which is probably a good thing for all of you guys. But today I'm going to talk about lung ultrasound, and thanks so much to Marco and the team for the invite to talk to you all. So a couple of things, I may as well get it out of the way before we talk about DVT, which is going to be at 11 o'clock. Conflicts of interest, as we always have to tell you. I do a fair bit of work with GE Healthcare Ultrasound. I've received honoraria from them. And I'm also the founder of criticalcarenorthampton.com. And that's about it. But I am a consultant in intensive care and anaesthesia at Northampton in the UK. Right, so let's crack on and talk about lung ultrasound. So, why do we bother with lung ultrasound? Well, to be honest with you, if there's any modality in ultrasound you should learn, I think it should be lung first and foremost. And the reason being, because it is very sensitive, specific, and we can pick up a lot of critical treatment decision-making options with it. And it's like shining a torch inside the body. So I think if you can learn lung first, then move on to heart, you're really on your way with ultrasound. And I don't know what you've been told, guys, on the course, but maybe perhaps the same thing. But do try and pick up lung first if you can, in my opinion. So that's why you bother with it, because it's very sensitive and very useful. Now, the other side to this is, for me in particular, and you may have seen me banging on about this on Twitter, I don't think stethoscopes are actually dead, because that's a bit of a grandiose statement to make. They're not dead, but they're very difficult to use on the ICU, particularly when you've got noisy ventilators, a noisy ward round, lots of machines beeping and pumps beeping and so forth. So for me, the stethoscope is pretty useless on the intensive care unit, certainly. But I'm not saying stethoscopes are entirely dead, even though this is clearly what I'm saying on that slide, but not very useful on the ICU. So, of course, we've got ultrasound in our armory, haven't we? So this is where it comes in really handy. So what I always say is, why look at the exhaust pipes when we can actually look at the engine itself? So bring in POCUS. And of course, this is a handheld device, and I'm a very big advocate of those because they're very useful and very easy to get hold of. A nice starting point on your ward round, then you can move on to the bigger carts should you need a bit more information. But these devices are really, really helpful and handy to use. So the other obvious advantages to this, well, it's sensitive. It's very fast to do at the bedside. You can keep an eye on disease as it progresses or gets better. There's no transfers to other areas, no need for radiation, and it's repeatable. So you don't need to bother with any of this stuff. And of course, at the top there, you can see the good old donut of death, which we will go on about. We don't want to be transferring patients to. So you don't need to with this. So how do we do lung ultrasound? And as I've said, if you can pick a probe up, get your orientation right, I think this is an easy modality to learn. So let's talk about how. This is a beautiful slide from one of my colleagues, Kuro Morales, and he is showing us nicely here that if you put the probe in the same position as you would place your stethoscope for examination, even at the back of the patient when they're proned, as in COVID cases on the ICU, you can really discover quite a lot of information. And if you look underneath here, particularly on the right side, we're getting most of the lobes of the lung in view simply on the anterior points. And of course, there we are again at the back, useful for proned patients. And I've done this multiple times with our cohorts during wave 1 and wave 2. And this is Daniel Lichtenstein. And if you guys get to meet him, he's a fantastic guy, a very small Frenchman with a big bad attitude, smashing up the stage and audio equipment and things like that. But he is a fabulous person to meet and talk to. And he was the man who discovered all of this and put it to the fore. And he came up with the blue points. If you look here, where he's placing his hands, it's pretty much a letter B. So hence comes the blue protocol. And if you place your hands there, that's more or less where you put your probe on the anterior points. And of course, round the other side there at the back is the classic PLAPS point, where you need to dig your probe into the bed and dip the tail down to see the bases of the lung. But we'll talk about this in a second. So what is normal on lung ultrasound? So I'm going to show you some sort of kind of animated things, and hopefully it'll make some sense to you guys as to what we're supposed to be looking at. So let's draw out the anatomical points we need to look for. Here's a lovely scribbled version of a color schematic, and here are the appropriate labels and what we're looking at. So at the top here, you've got your skin, just there, and then we're going down to subcutaneous tissue, and the intercostal muscle is quite prominent in a lot of patients, particularly if they're thin. And of course, around the sides here are the pillars of the washing line, the ribs. And in between here is the classic pleura. So I call it the line in between the pillars of the washing line. It does look like a washing line. And below this is the acoustic dropout of the rib, which appears to be black. Here is the area we're looking at, the lung underneath. So the pleura and the lung, and here is your window through. So if you look there, we have a very narrow window of looking into the lung, but it is a very adequate one if you get your views right. There's the pleura, and that's what we're focusing on. And this is a linear probe view. You can see that because it's got a kind of square image on the screen. So the pleura can be seen very clearly. And here is me, and this is my pleura. And you can see it, if you can just appreciate this, if you turn your gain down on the scanner, you will be able to see this pleura sliding backwards and forwards. If you turn the gain down, it just seems to stand out a bit more on the screen. And here's the classic rib, acoustic shadow, rib, acoustic shadow, and there's the skin, subcutaneous tissue, and the intercostal muscle in between. There is your washing line of pleura. And just below this, there are some horizontal lines, which we'll talk about in a second, and you can see them repeating all the way down the screen. So let's strip that down, scribble all over the thing, and strip it backwards. And you can see what we've just described before with all the anatomical points, as I mentioned. And here is a bat. Now, clearly, this is a bit silly, but they do describe it as a bat swing appearance, and this is what I'm trying to get you to appreciate. It sort of is, I guess, but I prefer the washing line approach. There's all of the structures we've built already, and again, the pleura, and it should show up and white, and it should be glistening like a slithering snake in between those ribs. Let's just highlight the pleura there for you. And also this line underneath here. Now, this is a reflection, an acoustic reflection of the pleura beneath the pleura, and it's known as an A line. And it runs across the screen, A for across. There we go. So the A lines travel horizontally across the screen. So that's what that is. And you can see A lines in nice normal lung, and you can see them obliterated in certain conditions as well. Now, if you look at this now, these things coming down like laser beams or things hanging off the washing line, they're known as B lines, and they run to the bottom of the screen, B for bottom. And they should run straight from the pleura all the way down your screen, and there should be no interruption in them. If they run from the pleura down and stop, those are not B lines. B lines travel all the way down from the pleura to the bottom. So there we have B lines running to the bottom. B lines are normally abnormal. So we don't really want to be seeing B lines, and B lines are there because there is some fluid in this lung. This is all air in here, which is why it's quite black and boring. But when fluid gets into the lung, it allows the sound waves to travel through with increased speed because sound loves fluid. So therefore we see them as lines going to the bottom screen. So those are a very, very important thing to look for. This is my lung base, and this is the right-hand side. That's the liver at the top there. Here is my kidney there, and this is Morrison's pouch, the space in between the liver and the kidney, and you've seen this on abdominal ultrasound, I'm sure. Morrison's pouch, and here is the diaphragm there. My head is here, so I'm going to do a stupid drawing here. There's my head with a smiling face on it, and my feet are somewhere here. I've got quite small feet, actually, so let's put those there. And this is the lung sitting down here, which is pretty boring and black. and the other structures there, as I've said, are the liver and so forth. So that looks quite boring and not much to see really, and that's normal lung. So you don't really see too much. It certainly should not look white like these structures here in between, and it shouldn't be as white or the same texture as the liver, by the way, and we'll talk about what that is in a minute. Strip it all down. Let's remove the crud for you. You don't want to be seeing that. And then we'll label all the structures up so you can see what I've just mentioned. And there you go. Here's the structures I've just talked about for you, just so you can get that into your heads. The lung base on the left, the kidney, diaphragm, Morrison's pouch, liver, and the spine at the back. Now, the reason we can see the spine at the back here is because the abdomen contains fluid. So that will allow the sound waves to travel through and show us the spine. If you see the spine up here, you need to get your heads together and think there's something not right that's allowing me to see the spine here. And it may mean there's fluid in this lung or a pleural effusion. That will then allow the sound waves through and you'll be able to see the spine at the back. So the spine sign is something we don't want to be seeing. Okay, so why does that pleura look like it does on the ultrasound? Well, I'll just try and demonstrate this. Here's the lung focusing down. And if you imagine the parietal pleura is the top section and the visceral pleura is the pleura sitting on the actual lung itself. Those two are stuck together with surface tension with the surfactant, and they slide backwards and forwards. And this here is what we see. So this area here is what we see as the sliding pleura and the glistening washing line in between those ribs. If those two are still together, if they are patent and stuck together. If they separate out in a pneumothorax, we don't appreciate the sliding pleura because they're simply not there. So here's some more of my normal side, and this is a portable device, and you can see here pleura sliding beautifully, and look at that A line underneath. You can see it really clearly. So the sound waves can travel all the way down through air. It's rubbish, air's rubbish at transmitting sound. So this is what we appreciate, but we do get that reflection of the pleura as an A line. So this is normal lung on that side. Here's the other side, and I'm taking huge deep breaths in here, and you can actually see abdominal organs coming in and approaching and encroaching into the view just there. But this is all normal. Going into the base, and you know this now. Here's the lung, diaphragm, liver, kidney, Morrison's pouch. And the other side, here is my spleen, kidney, the linorenal angle or splenorenal angle, and the lung and the diaphragm underneath. So those are all normal views. Okay, so let's think about a patient who's hypoxic. This is the blue protocol, and I've just adapted it a little bit, and you can download this from the website and use it and throw darts at it, do whatever you want with it. So let's think about hypoxia. What are we looking for on lung? How can lung ultrasound help us out? So step one, let's scan the anterior points on the chest here and here, as I've shown you before. Is the lung sliding? So do we have that nice sliding pleura? There's the first question. If it's present and you're still hypoxic, are the B lines there? And we know what those are. If there's diffuse B lines with a sliding pleura, it could be very, very diffuse B lines like laser beams in a disco. That could be pulmonary edema. We need to think, perhaps there's something wrong with the heart here now, actually. If you can see A lines all the way down, well, obviously, there's no problem. The pleura is sliding. There isn't a pneumothorax, but why else are they hypoxic? So perhaps we should look at the veins now. And this is where DVT scanning comes in. And oh, look there, we've got a DVT sitting in the femoral vein near the saphenofemoral junction. Then it's likely the hypoxia may be caused by a pulmonary embolus because you've got all of the normalities of lung ultrasound. However, you've compressed the veins and there is a clot. So we need to scan further. If there's no DVT, the next point is to go down the bases of the lung, scanning those basal PLAPS points there. Now, is there consolidation? Well, if there is, it's probably pneumonia causing the hypoxia, and you can see this down there, but I'll talk about this a bit further shortly. If there's no consolidation, then it could be COPD or asthma as the cause, if you're seeing normal lung under there. Okay. Now, if the sliding is abolished, and you can see A lines, B lines, and C lines, so those are abnormalities coming off the pleura, but you can see normal A line profiling, you might actually have some pneumonia showing at the anterior points of the chest at the top, causing the hypoxia, which causes a really gacky, horrible looking white sort of sheen to the pleura and below it, just below it. If the B lines are very widely spaced apart, and you can see some areas of normal lung down here, like we're showing, then that's pneumonia again, causing the hypoxia. If you don't have any of those, your pleura is not sliding, and you can still see your A lines down, well, look for what we call a lung point, and I'll show you this in a minute. That could be a pneumothorax causing a hypoxia. And obviously, then if there's no lung point to see and there's nothing else on this side of the screen either, you need to do some further tests, and there could still be a pneumothorax. So that's the blue protocol. It's very advanced to go through, but once you get your head around it, it's a really useful thing to be able to use. And there's your A lines and B lines again, showing they go across and down the screen. Okay, let's talk about some pathologies for you so you can get your head around what I've been describing previously. So the first thing that everybody wants to be a big hero over and diagnose with ultrasound and do a critical treatment decision and decompress the chest is, of course, the pneumothorax. Now, here is this lung point. So if we scan at the front, here's a CT and here is the normal scan, you can see that we've got pleura that is not sliding at all. Can you see that? It's there, but it really isn't sliding backwards and forwards. If we then scan down to the normal lung point, you can see you've got that sliding pleura, and you can appreciate these little tiny lines coming off the washing line. Now, if we get to the point between the two, here's your lung point where the normal lung sliding meets the pneumothorax point. You can appreciate that just here. See that? That's a pneumothorax. That is pathognomonic of a pneumothorax, a lung point there. And I hope you can note that CT. It is again, we can really appreciate normal lung sliding here, and do turn down again, and you'll see it and appreciate it much more. You can see an A line underneath there, and this is the pneumothorax and the abnormal lung under there, which is not sliding. I hope you can still see this because it did say my internet connection was unstable there. Now, there's something we can do. We can shine M mode, which is motion mode, through the pleura. If we're not sure about the lung sliding, perhaps put M mode through it. This is the normal M mode, shining down through, and the sliding pleura causes an interference at the bottom, which looks like the sand on a beach. And then it creates the sea and the horizon. This is where there's no chest wall movement, and this is where the pleura is sliding, causing the beach. So it's the seashore sign. That's normal. However, if there's no lung sliding, no pleura sliding, you will see what looks like a barcode all the way down the screen like this, the stratosphere sign. That, with I'm not sure whether the lung is sliding on B mode, means you've probably got a pneumothorax in there. Now there's this as well. If you look here, we've got an ECG on the screen, and you can see the QRS complexes here. If you look closely, you'll see a line of interference down this M mode ultrasound, and that's called lung pulse. If you get lung pulse, you have not got a pneumothorax. I'll repeat that. Lung pulse means you do not have a pneumothorax because it's allowing the cardiac pulsations to be transmitted through the intact pleura and across. So that means you don't have a pneumothorax. So that's another useful thing to look for. Have a look here, intercostal point 2. Sorry, intercostal point 5, say. Intercostal point 4 here. We've still got some sliding, definite sliding, but questionable. Moving further up the chest, definitely no sliding now. And here's the apex, no sliding at all. So there we have normal lung going into the pneumothorax at the top. Normal lung going into the pneumothorax where sliding becomes abolished. So you can appreciate that. Right, pneumonia. Really common thing to see on the ICU. Practically every patient who's on the ventilator, you will see this sort of picture on ultrasound. And I hope this connection's stable enough. You can still see this. Look at this shredded, horrible, white, reflective lung. It should be nice and black, not white like this. So this is all shred, and this is partial consolidation. That's what it looks like. And you can see some areas of probable parapneumonic fluid up there that's hypoechoic as well. Here's a really nasty one. Now, if you look at this lung here, it's all atelectatic, compressed, collapsed, and consolidated. And it actually looks similar to the liver, and we can call it hepatization if it looks similar in echogenic texture to the liver. Here's parapneumonic fluid as well. all around there, and there's the diaphragm down there. So this is a nasty collapsed atelectatic lung, and there's the spine at the back coming through, and that's actually mediastinum, but you probably see the spine further back. Here again is a handheld version. Echo bright lung, diaphragm, and the spleen below there. And you can probably, well, no, we can't, because that's mediastinum, but you can sometimes see the spine at the back. But this is a horrible, gacky, nasty lung. And you can see quite a high respiratory rate. And a patient who's struggling, you can appreciate that on the ultrasound itself. Paramnemonic fluid all around the back, consolidated lung, and there's the abdominal organ diaphragm there. And here it is again, just by wiggling the probe, dipping the tail. Here's a paramnemonic effusion, some tethered lung on the diaphragm there, and a high respiratory rate. So a suffering patient with pneumonia. Here's another nasty one. Got loads of these. You can see hepatized looking lung, and you can see areas of consolidation there coming through. Paramnemonic fluid layer just there in the diaphragm. Now, we all get very excited when we see dynamic air bronchograms, but here they are for you on the screen. You can see this movement of air and fluid sort of bubbling through, creating these pearls that come stringing across. Here's consolidated lung. It almost looks really clear like a liver because it's so compacted down and full of cruddy, horrible stuff. And here is the small paramnemonic effusion. Another one, look at these air bronchograms. Another one to get very excited about with the trainees on the ICU, and they think you're sad, but there you go. Here is a lovely pearly string coming up and down as the patient breathes in and out. So they're lovely dynamic air bronchograms to see on the screen. We're getting there now, guys. So another one, some more air bronchograms. You can see how sad we are in the world of ultrasound when we get excited about things like this, but you can really appreciate those on there. Okay, nearly there, pleural effusions. These are really simple to find because fluid is so damn obvious on ultrasound, it's black. Look at this, ribs, etc. But here is your layer of fluid. Now, when you're in the early stages of pregnancy, hopefully if you're a lady rather than a man, but if you're in the early stage of pregnancy and you need to have a full bladder so you can see a very small fetus. And this is why, because it allows the sound waves straight through and you get a lovely area of blackness and a very well-defined fetus. But this is almost the same effect, a bladder inside the lung. And here are some examples in a minute. If you measure the distance between the diaphragm and the most superior part of where the lung is coming back in, if you measure that in millimeters, you can then work out how much fluid is in the lung roughly. And there are various measures, but I like the Balick formula, which essentially is described on the screen here. Number of millimeters, or it says lung diaphragm distance in centimeters, and times that by 200, and you will get an estimated volume of pleural fluid. So that's a really nice one to do. And again, if you're unsure about that, I can show you this at the end of the talk again. And this is just another version, posterolateral distance from lung to diaphragm, greater than 50 millimeters. You've already got over 500 mils of pleural fluid in there. And I will just say, I wouldn't go bunging a drain into somebody necessarily with a pleural effusion unless they are acutely compromised, have an escalating FiO2 or on lots of oxygen, and I've got low saturations as a result. So you don't need to drain all of them. And here are some pleural effusions, handheld. You can see this lovely wispy bit of lung coming in amongst the fluid at the posterolateral point. The spine would be at the back there. And it's so big, this pleural effusion, that actually even with linear probe, you can see that lung skirting its way in. This is the costophrenic angle here. And you can see the lung coming through, desperately trying to grab through. Because I'm sad, this is a massive pleural effusion I found on a patient with COPD, and I actually had really good echogenic windows on the wrong side of the chest, and I was thinking, why the hell is this going on? It's because of all this fluid. And sadly, it looks like seaweed or coral sitting in the chest. But this is a big proteinaceous chronic pleural effusion. We did drain this because the patient really suffered. You can see paradoxical diaphragm movement during respiration as well. There you go, masses of pleural fluid. Here it is. And look at this wispy lung coming in. People describe it as a witch's hat or a sea anemone or something like that. But of course, I'm sad, so I've labeled it like a crab's claw. But you can really appreciate that. Have a guess what animal I've labelled on this one. You'll never will, but massive pleural effusion, collapsed atelectatic tethered lung diaphragm, and it's a slug, look. I really need to get out more. Another massive pleural effusion, and you can see areas of lung coming through, proteinaceous swirly fluid. Do dip and lift the tail of the probe up and down. Have a good fan through the lung, because bear in mind, you are seeing sort of kind of a 2D to appreciate a 3D image, but do fan through and see if there's anything else you're missing so you don't miss it. Look at this one. Horrible loculated, tethered pleural effusion, atelectatic lung. Probably not, well, if you put a drain in here, you need to be a bit careful because you may just hit one of the loculations and drain that and miss the rest. Finally, interstitial fluid. COVID, classic example of where we see interstitial fluid because of COVID, pneumonitis. This isn't COVID, but you can appreciate the laser beams coming all the way down, multiple B lines here. And of course, we may want to look at the heart as well, because it could be cardiac in origin, or it could be non-cardiac in origin, i.e. lung pneumonitis. There you go. That's what it looks like, laser beams in the smoke machine. And here we have multiple B lines coming off, very subtle, but we've got areas of normal lung. See that? Pleura, A line, normal lung. So this is a localized pneumonia, pneumonitis, apologies. And here we've got some thickened pleura, and we've got small consolidation sitting underneath just here. And sometimes this is what COVID almost looks like, with a thickened pleura, thickened pleural layer that everyone got excited about during wave 1. And this is a patient with chemotherapy-induced pneumonitis, high respirate, and B-line profiling coming through. You almost can't see any A-line underneath. This is what it looked like with the curvilinear probe, so multiple laser beams. And again, the other side of the chest, you can see multiple thick B-lines and an appreciation of almost a layer to the bottom. Very distressed patient we took to the unit. Putting it all together to close, scan your anterior point 1. Call it upper anterior or A1, whatever you like. It doesn't matter as long as you keep the same convention. And there's the image. Same thing. Multiple images. And I'm just showing you here, just minimize your depth and to optimize the frequency to see the pleura, or use a linear probe, but I'll show you that in a minute. Here's the lower anterior view. Pretty similar to the upper anterior one. You're just going a bit further down the chest. And then the PLAPS point, probably a bit further back than this. You really need to get your fist dug into the bed and dip the tail of the probe, or position the patient appropriately, and there's the lung base. Normal one coming through. If you want to use your linear probe, you can see the pleura really clearly. Now, I really love the linear probe for assessing the pleura at the upper anterior points, because you can see it so clearly. And I always have arguments with Ashley Miller, a good friend of mine, but we argue about linear versus curvilinear probe. I don't think it really matters, to be honest, but if you're using the curvilinear, do decrease your depth to optimize the frequency, and you're looking at the pleura, then you can go deeper to see structures below, but you can do that adequately with a linear probe in most patients too. So to close, and thank you for listening, this is 90% accurate handheld ultrasound, portable ultrasound, or the cart-based devices, versus one of these things which I can't stand anymore, and I never do chest x-rays on any of my ICU patients unless I'm assessing the direction a central line is taking. That's pretty much all I need a chest x-ray for these days. You can avoid it if you get good at lung ultrasound, and it is easy, and please try and learn it. Please scan the screen with your cameras, take that QR code, and it should take you to a tutorial that I did some time ago on lung ultrasound, and we've gone through it all on there. So do scan that and take a look. If you don't want to, that's fine. And do check out the website, quickcarenorthampton.com. So to close this, finally, we do inspection, we do palpation, we do percussion, and we do auscultation. But I've just told you auscultation is pretty much dead on the ICU because of all the noise. So why not insonate? Let's shine our torches into the body and see on the screen what we're looking for. Thank you very much for listening. And I'll see you again at 11 o'clock. Cheers, guys.
So thank you, Jonny Wilkinson, for this first part of your interesting lecture. And
I don't know if you can still hear me, guys. I do hope that the internet stream was okay. It is raining in the UK, and you know what we're like here. If it snows, the trains stop. If it rains, the internet stops. So I do hope that you could actually see all of that and there weren't any glitches. If there were, massive apologies. I'll see you shortly.
Perfect, thank you. So, and we will have now some hands-on sessions about lung ultrasound going on till 11:15 a.m. And then we will meet us again here for the next part of his lecture. Thank you.